Welcome to our series on perspectives on step therapy in oncology. I'm Jacob Kettle, oncology clinical pharmacist from the University of Missouri.
I am Rafael Fonseca. I'm a hematologist at the Mayo Clinic in Arizona and chair of the Department of Medicine.
I'm Kristina Rua, Director of Oncology Navigation for Sarah and East Florida Division.
I'm Lee Schwartzberg, medical oncologist and medical director of the West Cancer Center in Memphis, Tennessee.
Well, thank you all for joining us today. I think we should start our discussion, at least for this segment, talking about how to manage step therapy. And you all can clarify your experience with step therapy a little bit as we get going, but it is a reality of the world we live in oncology today. And so I think maybe we'll present a hypothetical case and then we can talk through examples of how you all would manage that situation and maybe provide our audience with some tips and tricks to navigate through some of those difficult waters. So the case I'll present, something I'm assuming you all are fairly familiar with. Let's say we have hypothetically a 62-year-old male with colorectal cancer, metastatic, already failed maybe first-line therapy with, let's say, FOLFOX, moving on to second-line therapy with maybe FOLFIRI. Request based on his condition maybe is to add G-CSF support prophylactically with that first cycle of FOLFIRI, and after you submit the authorization, the insurance, that gets denied for basically step therapy reasons. So maybe we can talk through examples of how you would handle that case, and hopefully we can extrapolate that to other scenarios that you've come across.
It might be useful to set the stage for our audience too as well about what step therapy is. And Lee, you have explained this to others before. Really, it's a parameter that is set through payers where medications, devices, and other medical interventions are approved in such a way that you usually have to try one before you have access to the newer one. Mostly this is a measure for cost containment, although there could be good practices, of course, that sustain why we do those things. But it's an idea that you must try some therapies before you try the newer ones, usually more expensive therapies.
And in the case that you're describing, the step is not to use G-CSF. So we're not talking about a substitution in this particular case, but we're talking about whether a supportive care drug is within the indication that the insurer feels is necessary.
Absolutely.
So I have a question to ask, sort of kind of to get a little bit more concrete as to what we would discuss further. For your case, did the patient when they were treated priorly, have G-CSF support or no?
Maybe for this case that
they didn't.
Maybe they didn't.
So from experience, that's something that comes up, like you said, often, and it's something that we do actually see, not in hypothetical cases. From my practice, I actually would agree that this is a good decision from the insurer's company. We don't necessarily know if G-CSF is actually something that is indicated in this case. They haven't had a treatment delay. They haven't been neutropenic before. So actually, in my book, I think that the decision was positive. Now, like you mentioned, the kind of focus of the segment is to discuss how to approach that correctly when the physician really did initially prescribe that. And I think it's explaining to the patient what it is that it does, what the rationale behind why it was prescribed was, and kind of give the benefit of, if you really don't need it at this point, we don't know that you need it, you're not going to, we're not putting you in a harm's way by seeing how you do the treatment. It's something that can be incorporated later on if need be. So I think that's something that I would personally, as a nurse navigator, when that's one of the questions that comes up all the time, the physician asked or prescribed this, why is my insurance not covering it, is to explain to the patient, this is the science behind it. It's intended to boost your immune system or to protect you from becoming neutropenic. And we don't necessarily know if you're going to do that. So why are we adding something on that potentially you don't need, that in the long run could have some negative outcomes for you if it was something that we were continuing to use? So that's something that we would do in the nursing side of the case, I guess.
So I think that's a really key take home, is first off making sure you're really clarifying with the patient why because from their experience, they probably left the clinic visit expecting one thing, they show up in the infusion chair with another. And so you've really encapsulated the importance of really providing detailed education to a patient to help offer that reassurance, so they don't leave expecting that they're in a dire situation, or their insurance company is evil, or their provider doesn't care about them. You've really provided the full story of explanation. I think it's really critical that when we speak to these issues, because they are so big and complex, that we speak to all sides of the story. Us as a facility, me as a pharmacist, you as physicians or nurse, what are your implications, but also what are the implications to the patient and also the insurance company. So making sure that that whole story is told, because if we are very isolated in our thinking, I think that's how things spin out of control very quickly.
Yeah, but I think an important nuance, and partly why we're discussing this, is because we can agree with extremes, and it almost doesn't matter what the outcome or what the behavior was. But the reality, the tension is going to be right there in the middle, where a medical prescribing aspiration, desire, or the writing of a prescription is in conflict with a structure that would say otherwise, right? And sometimes this step therapy has been referred to as fail first, and the idea that you have to show that something before did not work. And that's, I think, where the tension comes. And then certainly that's why we're doing some of this series, because there might be discrepant opinions of what is the best practice. Now, in this case, of course, you say that may be a good practice, but there may be others, and I don't, as a hematologist, don't have a strong opinion on this particular hypothetical case, but I could imagine there's many other situations where you're going to find 1,000 different opinions.
Yeah, I mean, if go ahead.
Well, let's change the case up and just say that the patient during FOLFOX therapy, the first-line therapy, had neutropenia and was hospitalized. And after that first cycle, they were placed on G-CSF appropriately, which would be guideline adherent, and then did not have another episode. So we have the history, and that's one of the difficulties with step therapy. It's done in a vacuum. It's to apply to everybody, and in one case, as the way you described the scenario, it makes total sense not to prescribe it unless there's an issue, because it's an unlikely issue.
Right.
When you have the history, then you want to prescribe it.
Yep.
So the problem then is, as Rafael said, you've talked to the patient, and we have an expectation, and then you have to change the therapy. So what is the process? In a community oncology setting like I'm in, we have to have a designated person, usually my nurse or my NP, who has to file with the insurance company, either through an online portal or more commonly through endless phone calls, and try to get the information that we want to have an appeal. So it starts with telling the insurance company that we need to appeal your decision. We think there should be a different outcome. This is a very long process. In my own experience, you have to do that. You have to go through several iterations with staff at the insurance company. And then to get a reversal, there's usually what's called a peer-to-peer. And you're at the mercy of their scheduling, the peer-to-peer. And the time is not inconsiderable. So it is often days to weeks before you get a decision to even present your case to a decision maker who can potentially reverse the step therapy approach.
Right. Yeah, and I think in the hypothetical too, this would be a case where evidence-wise, guideline-wise, you don't necessarily need, you wouldn't check the boxes of G-CSF therapy would be necessary in this case. You don't really need it with full fury. In the case, we didn't add any kind of features where it was required, but looking back, they have a history, they required it. Of course you'd want to supply that therapy.
Right.
And that's where I think the sticking point is their disease is relapsing. You want to get started on therapy right away. You may not have the luxury of waiting so long to go through all those processes. And then, like you said, you're at the mercy of when does your schedule and the third-party payer schedule line up to make that go through.
And I think to your first question, how do you deal with this in the real world? It gets complicated because, it's a gumption of the team, right? So if someone is not after this, and it often requires a second call and it requires a dedicated time, a lot of discretionary effort, of course, all of this uncompensated, that is built on the back of teams that are already stressed, the nursing teams, the physician teams, entering orders in the electronic medical records. So it is not something that is trivial. It has a huge impact on people's practices. And so I think the more streamlined we could have the practices, I think the better. Because without assigning any motives for why this may be in place, there is no doubt there's a game of attrition that, if people give up, they just give up and they don't get their drugs because either they don't know or because the medical team was not persistent enough. And that's, of course, is a bad outcome for a patient.
Well, and coming from the patient's standpoint, as a patient advocate, during this whole entire time, there's that delay, and you've got that anxiety building up. And I think a lot of it too is we really need to focus as as a team and as multiple modalities of making sure that the patient is aware. And I think a lot of the times that just adds stress that they haven't heard anything. They haven't heard from the doctor's office. And unfortunately, it's a burden for the practice to kind of keep the patient abreast as to what's going on.
Right.
But so that they know that there is an engagement, that you are really trying to focus on their care, and that you're expediting as much as you can. But, you know, like we've all mentioned, that you do have to go through the steps and the processes in order to get, you know, the outcome that you need, which is obviously the GCSF in the case, you know, that you've presented. So it's
Step therapy is very much front and center in managed care today. As of the beginning of 2019, there was new directives from CMS that Medicare Advantage plans, which is a managed care form of Medicare, and about 20 million people, I believe, are currently in them, have the ability to do step therapy for the first time. So this is actually getting more pervasive. It's not limited to third-party payers only, but in those patients with Medicare, that's now a new mandate, which again opens up a whole new swath of patients that we have to deal with this issue.
Well, and we've focused on our case on, you know, supportive care molecules, but maybe let's switch the discussion. How do you handle the situation where it's the therapeutic molecules that are being impacted? You know, you specialize in myeloma. That's definitely a disease state where there's a lot of ambiguity, maybe in certain areas. There's a lot of molecules out there and a lot of regimens, and how do you handle that when there is a big discrepancy between what you're trying to do for a patient and what the insurance company is willing to pay for?
So I'll start with simple. No one knows the answer. Why? Because at the end of the day, everyone is an N of one. If you were planning for a health system or from a payer perspective, of course you would want to have the ability and the foresight to be able to put some guardrails, even if they're soft, but that would be able to direct your practice. But myeloma is a great example. 11 new drugs approved since 1999, several of them with various approval at the various steps of therapy requirements for patient. Cover that with a layer of heterogeneity of the disease. And myeloma is less common than what you see, for instance, with solid tumors, but we have the same complexity when it comes down to mutations, translocations, the use of drugs for the different genetic subtypes, and then put another layer of, let's just call it patient features, be that comorbidities, social features, patient preference, etc., such the idea that you're going to be able to somehow move that Rubik cube and get it right set so that it's going to be right all the time. It's going to be nearly impossible. So we recognize from the get-go the challenge, even from the physician perspective, to stay on top of things. This is 100% of what I do is in my clinical practice is myeloma. I get all those emails and Google searches for myeloma, and I have to tell you, it's hard to keep up. When you just do one tumor type. So as you start spreading this out to every single tumor type, it gets increasingly complicated.
And the problem from the step therapy issue is you don't have the experience and the expertise of the Mayo Clinic making those decisions on what step therapy is. And one size fits all in myeloma today makes absolutely no sense. Plus, if the step therapy was for one drug and you typically prescribe a combination, then your whole schedule is thrown off, and then you can't give anything until you reconcile that. That must be a very difficult problem.
It is a difficult problem. We have, despite all these approvals, we're moving towards some clarity given some of the results of recent clinical trials. But I think your point stands 100%, that most of what we do now is in combinations, 3 drugs, we're moving to 4 drugs. And even taking the perspective of, I wish I could be in the side of that peer that I'm going to do the peer-to-peer call, who may be a retired obstetrician. How are we going to create that connectivity for the proper decision making? That is recognizing the difficulty in them having that, right? So in the perfect world, the peer and this phone calls would have the same level of expertise. So at least we could have that detailed conversation.
One area that I think we might have consensus in step therapy in therapeutics is the coming of biosimilars. I at least feel comfortable that biosimilars, based on the development process, even at the therapeutic level, which is now in solid tumors, have come and are coming in hematologic as well. It's a dawn of a new era. But if we're comfortable there, I feel that there's a lining up of savings for the patient, for the payer, for the practice, and for the provider to all make that decision comfortably.
Yep.
So in that case, I think most of the time it works. But even there are nuances where you may not want to use a biosimilar in a particular patient. So we need discretion.
Well, I think that's a great point that you bring up with biosimilars, just because it also makes it difficult, from a pharmacy's perspective, for us to run an efficient practice. If I have to potentially shelf 3 or 4 different versions of the same drug because of requirements from all the different payers that are in our patient mix, that can be difficult. Or, whatever your favorite flavor or disease is, what you see, if you have a preferred, sequence, maybe, if your patients aren't aligned with that sequence, it becomes very difficult to have a efficient, streamlined practice.
That is until Amazon has the Amazon drug Prime, right? So you don't have to stock these things. But your point is excellent. There was a recent report from IQVIA that looked at drug utilization, and it's very interesting because they call it the efficiency of usage. So they look at generics, 97%, meaning if there was a generic equivalent 97% of the times that is being used. Of course, that relates to some of these practices and the payers. But interestingly, in biosimilars was still pretty low, which was surprising. And I don't know exactly what are all the factors that are driving that, because we would all agree, in order to support innovation, we have to be ready to allow and support the transition towards the biosimilar, towards the generic market and all those things.
Huge implication, though, on a practice or in a health system in terms of managing the supply of drugs. I totally agree with you. And that's completely up to the contracting function between the payer. It's not really a step therapy issue.
Yep.
The drug that picked is going to be, but every payer negotiates with the manufacturer on what, and then we have the PBMs in the middle, and it becomes a very, very complicated system, totally out of the provider's hands. And you have to then pick the right regimen that uses one of 5 there's now 5 approved trastuzumab biosimilars. And if each company contracts and their step therapy designates a particular one, it's going to be very complicated and raises the issue of patient error in delivering drugs as well.
Well, and then you get into the delay in treatments, and that boils down to poor outcomes, stress. A lot of the times we've mentioned just kind of throwing in the towel because it just is so time consuming, and so it's so cumbersome to be able to cut through the red tape of being able to get it approved. So.
Well, I think we've touched on a lot of great points. These are difficult waters to navigate. I think it is very difficult, just to summarize, it is very difficult to create a system that allows for some operational efficiencies, but also is nimble to handle those unique scenarios. And I think that's what we're all trying to figure out. Thank you all for your time and joining us today. Hope you enjoy the rest of it in our series on perspectives on step therapy and oncology.